possible source of getting infected was tattoos, which he had gotten when he was much younger. He's a current everyday smoker. He has some degenerative disc disease, some other, he has musculoskeletal problems. He has problems with his hips, with his knees, but his FibroSure score was a F1, F2, and I get out of the middle of my, it says the meeting is being recorded, and it's right in the middle of my screen. Anyway, we do have him scheduled for a ultrasound. It's on December the 12th, and he follows up with his PCP, and he is going to get a second hepatitis B. He has recently remarried, and he seems to have a very stable home life now. So I think he would do well to be treated for his hepatitis. Any questions?
Thank you so much, Alice. That was a great case presentation. I do apologize. I had that little pop-up when it says recording, but you did great even with that pop-up right there. So thank you. All right. Did anyone have any clarifying questions before we jump into the feedback and recommendations? And feel free to unmute or chat in.
Just one quick question. I know we mentioned his risk factors are quite remote. Do we have any estimate of how remote? I'm just trying to get a sense of how many years head start hepatitis might have.
Well, he started in our practice in 2012, so that was about the time that he might have been infected prior to that. But he's been clean since 2012.
Thank you, Dr. Gilfus. Any other clarifying questions from the group? Right, and any of the hub members with recommendations or feedback for Alice? Dr. Gilfus, I noticed you unmuted there.
Yeah, sure. And I'm just going to pull up his results a little bit. So normal platelet count, normal APRI, and serum fibrosis markers that are low. Nothing suggests that this guy has advanced fibrosis or cirrhosis. So good news from that perspective. He's a genotype 1A. So all of our major treatment options are available to us. He does have Medicaid. So his preferred agents are going to be Mavorite or Epclusa. He's not on any medicines that look like we have concerning drug interactions. So really your sky's the limit with your treatment options. Mavorite for 8 weeks is certainly the shortest. And Epclusa for 12 would be equally valid. He will not require any long-term HCC screening due to the fact he's not got a lot of fibrosis. And I think this is a great time to treat this guy. He's clearly somebody who's gonna form some scar tissue because he's already got some. And remember, that's sort of a risk factor for future fibrosis if you're starting to get some fibrosis already after maybe 10 or 15 years. And the only other thing I was going to mention is to make sure his new wife is screened. You know, the sexual transmission's uncommon, household transmission's uncommon, but it can occur. And so everyone should be screened, but just even more so with the risk factors potentially. So that's all I got on her. Him.
Thank you, Dr. Gilfus. And Alice, did you have any other questions you wanted to ask the group about your case? You are still muted too.
The mute button is always somewhere different every time you go to a meeting. No, I don't. I think he'll do really well. He continues to stay in the MAP program. He does all of his UDSs are good. So I think he'll do fine.
Awesome, thank you. And anyone else from the group with any feedback or recommendations? Alrighty, sounds good. Thank you so much, Alice, again for that case presentation. We'll go on to the next one. Dr. Fournier, I think I see your case up next. If you're ready, we can go ahead and start with your first one, the 30-year-old male, if that's okay.
Okay, yes, I'm unmuted. Okay, the 30-year-old male, absolutely, thank you. I have a 30-year-old male that was referred to me by a nurse practitioner in our practice. He had been a prior injectable drug user. He's 30 now. He was a user between the ages of like 24 and 26. About 4 years ago, when he decided to get help, go to rehab and get clean, is when he found out he had Hep C. He's never been previously treated or previously sought treatment. He's a healthy young man. He does have a history of hypertension, for which he takes lisinopril. He has had his first 2 doses of the Twinrix vaccine, and he won't get his last one until sometime in the spring to complete that series. His genotype is 1A, and his viral load is at 1.6 million. His APRI was low at 0.4 with a child Turco-Pugh class A and a MELD of 9. He's, like I said, long time clean. I think this is a good time to get him treated. I did not do a FibroSure on him. We actually just added that lab last week. So that is something I could do, although I do think he's a low risk for fibrosis, but I was hoping to seek treatment for him with like the Mavreet.
Awesome, thank you so much, Dr. Fournier. Anyone with clarifying questions for Dr. Fournier in the case? All right, and anyone with any feedback or recommendations?
Mitra, it's John again. And again, if anybody else wants to give advice, I'm sure they could do it more eloquently than me. But Dr. Fournier, I agree with you 100%. With this case, you've very well delineated when the risk factor was, and we know when he was likely infected, and we know that there's no more than he's clearly less than a decade's worth of hepatitis. So we're looking more like 5 years or 6 years or something. And you know, with a genotype 1A, it's one of the common ones, and it's not one of the ones that progresses extremely rapidly. So it's not genotype 3. If it were genotype 3, with a decade or a little less than a decade's worth of infection, you can see significant fibrosis. If a patient has significant immunosuppression, such as HIV, organ transplant, or frequent use of other rheumatologic agents, you can see more rapid fibrosis. But this guy's case is clean. I agree with you 100%. I don't think you need to make him even get a FibroSure. You know, we don't have any drug interactions. I think he's worth treating kind of early on, because if you look at his ALT and AST, you know, if you did get a FibroSure, the other thing that you get on that is something called an activity score, which sort of is like how quickly are you going to progress towards fibrosis even before you get it. I bet his activity score is high. The more cost-effective version of that is just looking at your transaminases. And, you know, he clearly has some inflammation going on. So yeah, awesome guy to treat. Same thing. And again, we have Rational Drug on who represents Medicaid. So please speak up if I'm misrepresenting your formulary choices, but I think that the formulary choices are primarily going to be Epclusa, again, 12 weeks, or Mavreet for 8 and either choice would be valid.
Yep, absolutely. That's all correct.
I appreciate that.
Thank you, Dr. Gilfus and Angie for the feedback.
Oh, and I'm sorry, I forgot to mention, no long-term HCC screening, obviously, either. So good reason to treat them early. You should be good and cured and never have to think about it again.
That's awesome. Thank you. And Dr. Fournier, do you have any other questions about this case in particular?
I don't.
Awesome. All right. Well,
This
if
is
you're
Rachel.
okay-
I just wanted a clarifying question if I could, really for Angie, just to double check. So a lot of times when we submit things for RDT, they do require like a fiber test, a FiberSure, or an elastography. We've not always had success with APRI scores, and it's kind of hit or miss sometimes with ultrasounds. Angie, can you clarify like what kind of fibrosis kind of assessment you guys will take from that standpoint? Because while we were talking here, I was looking up the criteria. I didn't see anything spelled out specifically, but there is a spot on the PA form for a fibrosis. And I just know a couple of times we've got them kicked back because we didn't have a specific fibro test or an elastography.
Now, I appreciate you saying that because I know when my staff enters it, they say they can't get to the next page electronically unless they fill something in there.
Right.
Sorry, I think I was muted. Do you know if that was recent, if the fibrosis score came back as a pending? Because I know for sure we pushed for it more so when the approvals depended on fibrosis. I know we still do have to document fibrosis to Medicaid, but I can reach out to them and see if they have any strong feelings on if it has to be a FiberSure or elastography. I know it doesn't have to be elastography, but whether we'll take an APRI or not.
Okay.
And I can email the group.
Thanks.
Yeah.
Rachel, thanks so much for bringing that up too. That's a great point.
Mhm.
Awesome. Thank you all so much. Were there any other feedback or recommendations anyone wanted to add? Alrighty.
Just for those who are new on the call, remember we're concentrating on the drugs that we routinely use, but Harvoni would be an option as well. It's less than 6 million viral load, so you could do 8 weeks of Harvoni as an option. And then Zepatir you could do as well with genotype 1A, but your duration would really depend on extra polymorphism testing. So we tend to avoid the complication of going to Zepatir. So just to be fully representative of all of our treatment options for genotype 1A.
Thank you so much, Dr. Gilfus. Alrighty, Dr. Fournier, if you're ready, I can pull up your second case.
Mhm.
Awesome.
Thank you.
No, thank
Sorry,
you.
everybody. Me again.
No apologies. We love it.
Okay, this young lady was referred to me through our MAT program. She has been successfully in our MAT program for some years. She was an injectable drug user for 8 years, quit a little over 4 years ago, and been in the MAT program since then. At that time, 4 years ago is when she found out she had the Hep C. She's never been treated. She had been referred to a GI doctor who she felt had really chastised her about her drug use, about that she smoked weed, and they said, insurance would never cover it if you do these things. So she hadn't thought to ask to get treated again until our MAT program said, no, I really think you should pursue this. So she came to me actually really nervous about this because she was afraid that she was going to be looked down upon. She even brought her mom with her and everything. Her health comorbidities are bipolar disorder, mild asthma, lumbar DJD, spine. And I asked actually why she smokes weed, and she said she does, and she's not a daily marijuana user, but semi-regularly. She says it helps with her pain. So when she said that, when I did her labs, I did check a rheumatoid factor too, and it is positive there. Although her pain is more generalized and not sometimes joint pain. Nothing on her exam looked like any significant joint deformities thus far, thankfully, but I think she's at risk for rheumatoid arthritis. She has a fairly extensive medication list, mostly because of her bipolar, but I have those listed with the Paxil, Suboxone. She's on a Ceravent for her asthma, ProAir as needed, Trileptal, Benzaprine, Gabapentin, Cyclobenzaprine, Abilify, vitamin D. She received her first Twinrix vaccination in early November. Her BMI is at 30. On her labs, her ALT and AST were relatively normal, APRI of 0.3, Class A on her Child-Pugh, MELDS of 6. She is a genotype 1A with a low viral load at 130,000, which I thought was low. I did do a ultrasound on her, though I had ordered it that first day, even before her repeat viral load was back, just because she had been a number. I didn't know at what point she got infected, and it was completely normal. So I was, again, yes, I did not have a FiberSure on her. We do now have that available here if that, but with the low APRI and a normal sonogram, I thought maybe it wasn't needed, but I'll leave that to the recommendations.
Thank you again, Dr. Fournier. Any clarifying questions or just general questions for Dr. Fournier? Feel free to unmute or chat in.
Can the Hep A interfere with the RA test, or Hep C rather? I mean, it seems to me like we have discussed that sometime or another, that you can get a false positive RA in people who have Hep C.
Absolutely. Yeah, that's going to be a great pickup. And I'll talk more about that in a second.
Thank you, Dr. Rexroad. Any other clarifying questions? All right, and any recommendations from the hub members or anyone from the group, feel free to unmute.
I'm going to unmute if that's okay and ask Rachel Mitchell a question. This is John Gilfus, one of the infection docs. Rachel, is there any concern with her Trileptal?
Yeah, that's, I was gonna unmute and kind of say, like, to be the bearer of bad news, the Trileptal is an enzyme inducer. So it's one of the major 4 issues from the major 4 anticonvulsants that we kind of struggle with from a Hep C treatment standpoint, because all of the DAAs are going to be impacted by that drug. So they're all going to essentially cause the Trileptal and the other 3 are going to cause subtherapeutic levels of the DAAs, and we don't really have any way to overcome that. I can say that I've read some studies where people have tried, changing the dose of the DAAs and trying to overcome that induction, but the insurances aren't going to pay for those non-FDA approved doses, especially for the cost of the medication. So we don't really have a way to overcome that. Usually what I see the other folks do is trying to work with the prescriber of the Trileptal and seeing if there's like an alternate medication. So, Trileptal and Tegretol, phenytoin, and phenobarb are the main 4 that we really worry about. So trying to avoid those and going to something else that, and I know the patients are often hesitant to do that, especially if they're stable. especially when it's used as a mood stabilizer. So that's going to be the major hiccup from a treatment standpoint, is trying to get that medication changed to something that's not going to interact with the DAAs. Unfortunately right now, and I don't know, I've never seen all the studies that have been tried are usually like center specific, so not drug company specific. So I don't know the drug companies are really investigating that as an option to alter their doses in the future.
Thank you. I did kind of warn her that we might have to do some med changes to get treated. And she felt like she's been stable enough if we worked with her behavioral health team that she'd still like to proceed with Hep C treatment.
Great. And from the other medications on here from an adjustment standpoint, the only other concerning one would be the Abilify. And it's not a contraindication, it's just a monitoring thing with that one, primarily with, not so much with Epclusa, but primarily with Mavorite and then Zepatier, which is also an option for her. So those two, you could still use it, but since that drug can have some side effects and generally has a narrow window, therapeutic window, you just monitor for those side effects. You could still use those drugs, but it's just a generic kind of monitoring thing.
Okay.
And thanks, Rachel. Yeah, that's awesome.
Sure.
So really our major issues, this is John Gilpus again. Major issues for this one is going to be drug interactions. Do you do a short duration of the Mavorite and just watch for the Abilify, or do the longer duration off the Trileptal and go to Epclusa? That's a challenge. Thanks for clarifying all that, Rachel. I'm going to talk about one of the other things that Dr. Rexroad brought up real quickly. And that's when you do see a positive rheumatoid factor, how to approach it. And I'm so glad you checked this, Dr. Fournier. That's awesome. The rheumatoid factor from an infectious disease doc is just a marker of immune system activity. Remember, this is an antibody directed towards the FC component of other antibodies, usually IgG, and it is an extrahepatic manifestation of Hep C. And it can be, number one, just interesting. Number two, it can be consequential because it may imply that your patient is one of these people that's having a more immunologically profound response to hepatitis C. And what does that mean in layman's terms? It means that could, leave this person untreated for too long and they can progress to cryoglobulinemia, monoclonal gammopathies, and potentially even lymphoma. So it's these patients with the positive rheumatoid factor that sort of, you don't know how far along they are in that sequence of things. I do advocate, when you do have a positive rheumatoid factor, to do a couple follow-up labs at some point. One would be a urinalysis, just making sure you don't have any proteinuria. So the consequences here is that, again, if we indicate, or we imagine that rheumatoid factor is a screen for sort of immunologic activity of Hep C. And what you're looking for with the UA is any evidence of glomerulonephritis, for immune complex deposition, and therefore proteinuria. And also, this is worthy to screen for their CCP, whatever that CCP thing stands for, the cyclic, the true rheumatoid arthritis one, yes, and cryoglobulins. So, if your rheumatoid factor is positive, feel free to do those. This is more for clarity's sake. You're going to treat her. And I really think it's wonderful that she reestablished with you after having such a bad encounter with a judgy healthcare worker in the past. So I'm thankful she didn't wait until she presents with lymphoma 10 years from now or something. So good stuff. And also one other thing that my one colleague always reminds me on these young childbearing age females is pregnancy test right before you go through treatment. And again, not that the pregnancy, not that we know that there's any teratogenicity of the DAAs, we just don't know if they're safe. So it's not like Ribavirin, old days, we knew it was terrible for the baby, but these DAAs, we just don't have good data on. So we always have to prove that there's no pregnancy ahead of time.
Thank you all so much for the recommendations. Did anyone have any other comments about this case?
And I'm sorry, I'm blabbering a lot, but one other thing is you commented specifically on the viral load, and I think it's awesome. You look at it that it's Hep C is different than a lot of other of the chronic viral infections, where the viral load does not seem to be central to predicting the course of how things might go. So if you look at HIV, viral load is everything. If you look at hepatitis B, viral load is everything. You know, a lot of our treatment decisions for hepatitis B are based on viral loads. For Hep C, man, you can see advanced fibrosis and extrahepatic manifestations even with low viral loads. And so, you know, basically, I almost view the viral loads as quantitative or qualitative. It's like yes, no. And so, I've definitely not been comforted by low viral loads except 0.
Okay.
Thank you for adding that, Dr. Gelfus.
Mhm.
And Dr. Fournier, did you have any other questions or comments you wanted to maybe discuss with the group about this case?
No, I mean, I appreciate all that. So should I add the FibroSure? Does it?
Nah, I don't think so. I think
Unless Medicaid makes me.
Yep, perfectly said. She's another one. You've got such a beautiful sense of where, you know, how long she's been dealing with the Hep C, and you're definitely going to treat her because she's kind of one of these people who's smoldering towards extrahepatic activation and stuff like that. So great patient to catch and re-engage in care. So that's awesome.
Thank you.
Awesome. Well, thank you again, Dr. Fournier, for the 2 cases. We really appreciate it. All right, Dr. Root, I'll pull up your 2 cases now if you're ready, and I'll just turn things over to you.
Let me see which one's first. Okay. So first is this gentleman. He's a 66-year-old male. He has been a longstanding patient in our clinic. He had his annual physical done in March of this year, and they did hepatitis C screening on routine labs, and he was noted to be positive. He has had kind of a difficult year otherwise. He had a tubulovillus adenoma on colonoscopy, so had to get a right hemicolectomy. He did well after that. It was completely removed and didn't need to see oncology. He also lost his wife that he's been married to for a long time. So he saw me in September of this year. On exam, his blood pressure was fine, his heart rate was fine. He did have a well-healing scar from that right hemicolectomy that was done over the summer. The only risk factor I could come up with for him was that he was incarcerated for 6 months in 1975. He's never used any recreational drugs, never had any tattoos, never had a piercing. He was married to the same woman for a long time, and she never had any risk factors that he knew of, and she was never diagnosed with hepatitis C either. No blood transfusions in the past. I mean, really the only thing I come up with was the incarceration. His other medical problems, he has hypertension, for which he takes carvedilol and lisinopril hydrochlorothiazide. He has hyperlipidemia, is on atorvastatin for that. Sleep apnea, he uses CPAP at night. Asthma, he has albuterol that he uses as needed. And then the colon cancer that was diagnosed this year. And then he takes Cialis for erectile dysfunction. So he is not immune to hepatitis A and B. We've started vaccinations for those. His BMI is 36. On labs, he has an anemia with a hemoglobin of 9.7, but that's kind of at his baseline. His platelets were a little bit elevated at 455. His PT and INR were okay. His AST and ALT weren't super elevated. His bilirubin was fine. His APRI was 0.1, CTP of 5, and a MELD score of 8. Other labs, his vitamin D level was 18.5, so we are replacing that for him. His HIV was negative. His genotype was 1A with a viral load of 5.1 million. His serum fibrosis marker was F1 to F2. So I am waiting on an ultrasound for him to come back. And then his Hep B serologies were negative. So one of my main questions for him was the process of getting medications approved through Medicare, because the only process I've gone through was Medicaid.
Thank you so much, Dr. Root. Did anyone have any questions about the case or comments? Any clarifying questions? All right, and any hub members with feedback for Dr. Root and the case?
This is John. I want to punt two things to Rachel Mitchell. Sorry, Rachel, I'm doing a lot of that today. You know, when you peruse med lists, one of the categories of medicines that needs to catch your eye is the statins. And Rachel knows these much better than I. And I was wondering if you could maybe talk to us about the statin, because there's some contraindications with Lipitor and some of the DAAs.
Sure thing. So with the main two statins that are always I always call them the problem children because they have the most issues is atorvastatin, like this patient, and then rosuvastatin. So for this patient specifically, with the atorvastatin, the one that you would want to avoid from a DAA standpoint is Mavorite. Technically, the two are contraindicated to be used, and the reason for all of these issues is because the DAAs all will increase the concentration of the statin, so it puts those patients at risk for those statin toxicities, so the myopathies and those sort of things. So Mavorite you're going to want to avoid in this patient. Harvoni and Epclusa just have that sort of generic monitoring warning with them. So I usually just educate patients, if you notice that you're having muscle pains worse than, normal, then go ahead and, let us know because we can lower the dose or something to that effect. The other one is Zepatier. That one, the max dose of the atorvastatin is recommended to be 20 milligrams. So that would be cutting it in half for this patient. It looks like he's on 40. So to recap, Harvoni and Epclusa, just monitor and make adjustments if necessary. Mavorite is contraindicated, and then Zepatier has a max dose recommendation of 20. So depending on which therapy you decide to go with from a DAA standpoint, it's only 8 to 12 weeks. So if the patient doesn't have a significant cardiac history, if they haven't had a recent MI, I know a lot of prescribers are usually okay with just stopping the statin for that short time while they're on therapy to avoid the interaction or making any changes. So that's sometimes the easiest thing for the patient to do is just hold off on that while they're taking their DAA. But alternatively, you could lower the dose or change it to a different statin. I don't like that idea, just as a selfish plug for myself, because I feel like patients get confused when you change their dose and then the pharmacy has 2 different prescriptions and they don't know which one they're taking. And if you have to do it, you can, but I'm not a fan of that one if we can avoid it, just for ease. And as far as the Medicare goes, that's why I went through all 4 of them, because depending on what tier and what plan they pick, their formularies are all really different. So it's just, we just have to do, a benefits investigation, figure out what their formulary is, and then pick the agent based on that. If you have everything from a lab value standpoint that you need for Medicaid, then you're probably just fine for Medicare. Usually Medicaid is the most strict. So that's sort of the guideline I always recommend. If you have everything you need for Medicaid, then you're probably good to go from a Medicare standpoint. Usually you can do those on the phone, or at least start the process over the phone. They may want you to fill out a form, but they'll give you all that information. We usually just call the number on the patient's card and get that process started for the figuring out the formulary and then prescribing and going from there.
Thank you.
Thank you so much, Rachel.
Sure.
Dr. Gilpus, I noticed you have muted as well.
Yeah, Dr. Root, awesome job, great presentation. So basically, this guy has 46 years of hepatitis C, possibly, and has certainly some fibrosis documented, F1, F2. And just for the sake of just discussion, remember that fibrosis can progress non-linearly. That's a hard word to say. Linearly, it can progress more rapidly all of a sudden. And so certainly, even though he's only F1, F2 after 46 years, we don't want to wait. So what risk factors does he have for more advanced fibrosis? Well, his BMI. So he's probably got some fatty liver in there. And it's kind of old data, but low vitamin D can certainly set you up for more advanced fibrosis development. So I love that you're jumping on his vitamin D. Glad you're going to get him treated. Maybe you can do the hardest of all things and make him lose weight. That's on everybody's wish list. In terms of therapeutic, I personally would either go Epclusa or Harvoni. By the books, you could give him 8 weeks of Harvoni, but I probably would just give him 12. He's a bigger fella. There used to be a very interesting prohibition on giving 8 weeks of Harvoni to African American patients. That's since fallen off the recommendations. But it used to be to do 8 weeks of Harvoni, you had to have a viral load less than 6 million. You had not have any really immunocompromising conditions like HIV. You had to not have cirrhosis. And we used to have this cannot be African American. And that's as far as I know now gone from the recs. So I guess by the books, he's less than 6 million. But we all worry a little bit about BMI stuff. I know Rachel Mitchell's gone over this before. They studied Harvoni up to BMIs of like, I think 60 or something really high. But yeah, I'd just give him 12 weeks of one of the two. Go from there. And then he's somebody to probably, just see what happens over time. Maybe get one more fibrosis marker in a year or so after you treat him, just to make sure he's not having fatty liver stuff go on and, a bit more advancing fibrosis due to basically not hepatitis, other reasons.
Thank you.
And Dr. Root, did you have any other questions about this case for the group?
No, I don't.
All right, awesome, thank you. So if
Can I
we're-
ask one question?
Absolutely, yes.
Well, I don't know. You're Dr. Gilfuss, you were going by all those things that, the risk low vitamin D being a risk factor for advancing fibrosis in people who have fatty liver and Hep C. Does it also advance fibrosis in people who have fatty liver but don't have Hep C?
That's a great question. And believe it or not, I think the data is mostly, we've extrapolated it from hepatitis B. Most of the stuff I've ever read, when I've tried to find what are optimal ranges for vitamin D, it's not well established. And most of the stuff I find is actually for Hep B, chronic Hep B. And the data is from, because Hep B is so common in other countries, it's really easy to do international, giant studies on Hep B. Hep C, it's a little more challenging. And so I don't know. It's a good question. So it certainly holds true for Hep B and Hep C. So who knows from other standpoint? So great question. I don't know. One more reason to get vitamin D. One more reason for more sunshine.
That's what I'm thinking. It gives us something more in the arsenal when we're talking to people about vitamin D.
Thank you so much for that question, Dr. Rexroad. Did anyone else have any questions that they might have wanted to ask about this case or unrelated to the case too? Alrighty. Well, Dr. Root, if you're ready, I can pull up your second case.
Right. All right, so this gentleman is a 70-year-old male. He is kind of new to our clinic over the last year. He had a traumatic brain injury in 2018. I can't really find great records on it because he lived in Virginia at the time, but it sounds like a fall with intracranial hemorrhage at the same time. So he's a pretty poor historian. He moved to our area to live with his daughter about a year ago, and that's when he established with our clinic. His hepatitis C was diagnosed prior. I don't know when it was first diagnosed. He can't tell me, but daughter said it was known that he's had hepatitis C. He did have a lifestyle with some risk factors before the traumatic brain injury. So he did use drugs at some point, but he can't really tell me how he used them or what they were when he stopped. He was an alcoholic before as well. Since this traumatic brain injury, he was kind of in and out of SNF living in Virginia until he moved to his daughter's house. And now he's a little bit more independent since he's been here. And he no longer drinks alcohol, hasn't used any recreational drugs, at least in the last year, per daughter. His comorbidities include anxiety, depression, a seizure disorder, COPD, AFib, and GERD. So he is on albuterol as needed. He takes Keppra for the seizure disorder. He's on memantine, omeprazole for the GERD, venlafaxine, Sotalol, rosuvastatin, and Spiriva, and he also has a prescription for sildenafil. So he is immune to hepatitis A, and hepatitis B he is not immune. We have started the vaccine series for him. His BMI was 30.4. On labs, his blood counts were okay, his platelets were okay, his creatinine was 1.12, PT and INR were normal, his APRI is 0.1, CTP of 5, and a MELD score of 10. His vitamin D level was low as well at 18.5. HIV was negative. He is genotype 1B with a viral load of 1.4 million. His serum fibrosis marker is F3. And then his Hep B serologies were negative. So for the serum fibrosis marker, I have ordered a liver ultrasound and an AFP for screening for HCC, but he has not gotten that done yet. So for him, I was worried about, because he's on a bunch of medicines, I was wanting to make sure that there was nothing that was going to interact. And then we already kind of talked about the Medicare piece of it because he has Medicare as well.
Awesome. Thank you so much again, Dr. Ruth. Any clarifying questions from the group? Okay, and any feedback or recommendations from the hub members? I know you asked about drug interactions, and Rachel and Angie both do a wonderful job talking about that in their didactics. So maybe I can throw it to them first.
Sure thing. So from a drug interaction standpoint, the good news is that the Keppra is not one of those anticonvulsants that we're worried about. So that one's good. There's no issues with that one. The main issues here are the annoying ones that always seem to creep up with the PPI. And then again, this one's on a statin again. So we'll have to do some workarounds, but there's some good news with that. So with the rosuvastatin that he's on at this point, the dose is okay with most of the DAAs. Harvoni in this case is actually one of the ones that's not recommended. So you'd want to avoid that with any dose of the rosuvastatin, but the 10 milligrams is the max dose for the rest of the DAAs that we see for genotype 1s that we can use, the most common, the Mavorite, the Epclusa, and the Zepatier. So they'll still come with that, monitor for any myopathies or whatnot, but there's no reason to, at least on the front side, stop the statin, and there's no reason to adjust the dose. So just monitor unless there's an issue. The other annoying thing here is going to be with the omeprazole. So it looks like his dose is okay from a max dose standpoint. And this drug interaction, remember, is only with the Epclusa and the Harvoni. So the problem here is not actually the sofosbuvir, which you'd think because it's both of these drugs, but it's actually all the other agents, the ladipasvir and the velpatasvir in these two drugs. So the NS5As. So in these, what it is as that gastric pH increases or becomes more basic, the solubility of the drug actually decreases. So it doesn't dissolve, and then it doesn't get in the body, and then we're at risk for subtherapeutic levels. When they did the pharmacokinetic studies for this, and they were trying to find optimum doses, what they found is that once the pH went above 4, which is actually our goal with most of those PPIs, because we're trying to cure ulcers and things like that. But once that pH goes above 4, the concentration within the body was decreasing the AUC by like 60%. So that's huge when you're trying to worry about cure rates and developing resistance and things like that. So the recommendations are a little bit different whether you do Harvoni versus Epclusa in this case. With the Harvoni, the recommendation is this omeprazole 20 milligrams. This dose is fine, but for the patient to take the Harvoni and the omeprazole together on an empty stomach. That changes with Epclusa. Their recommendation is if the patient can hold the PPI, that's best. But if it's medically necessary and the patient cannot stop the PPI, it's omeprazole 20, so nothing else, no comparable doses or anything. And they changed up with the kinetics, they changed up the dosing recommendation. So they should be taking the Epclusa with food and then taking the omeprazole 4 hours later. So it's the hookup I always get with patients. They're like, well, I'll just take the Epclusa in the morning with food and take the omeprazole at night before I go to bed. No, it's 4 hours. So it's not at least 4 hours. It is 4 hours after that, after they take the Epclusa. And that's the way when they were doing the studies to avoid the interactions, that they saw the least amount of interaction and change in the solubility with the Epclusa. So it's a little bit annoying how they're different, but you can work around it. And then your option is always, if the patient, for both of them, if the patient can avoid them and not need to take it, that's fine too.
Awesome, thank you.
Sure.
Thank you so much, Rachel. Anyone else with any recommendations or feedback?
Dr.
Dr. Jeffers?
John, Rachel, thanks. You say that so much better than me. Yes, I'd probably go with Maverick for all those reasons. Just going to be the easiest. And then, Dr. Rood, I would congratulate. I think it's great that you did the ultrasound. That was literally the only thing I was going to make sure. This is one of those cases where you already got advanced fibrosis, and regardless of treatment success or failure, but hopefully success, they'll need HCC screening forever. Will clearly decrease his likelihood of developing HCC by treating the Hep C, but it'll never get to baseline. So even if he's a cure, that scar tissue can be pro-oncogenic. And so you got to do HCC screening with just an ultrasound every 6 months for as long as you see him.
Thank
So-
you so much.
Sorry, do you not have to do an AFP for HCC screening? Is it just the ultrasound and then you get?
Yeah, great question. So we just have to do the ultrasound.
Okay,
That being said, I sometimes talk to patients if I'm going to get blood work for other reasons. And on occasion with an interested patient, it's much like a PSA. You can open a hornet's nest, sometimes finding information that you don't know what to do with. But in general, if I've got a highly medically literate patient who I can have a good conversation with about the limits and benefits of tumor markers, some of them really like it, especially those who get sort of ambiguous reads on their ultrasound, where sometimes you get a ultrasonographer who hedges their read and puts a bunch of conditions on there, like sometimes hedging on the comfort level which they can read it. And in those scenarios, I will jump to an AFB and stuff like that. Usually for make the patient feel better. The dread thing is if you get an AFB of 9 or 10 or 20, one of these borderline elevated ones you don't know what to do with, and a normal ultrasound, then you're kind of stuck doing an MRI. But if it's stone cold negative, it makes everybody feel better. I check them probably about a half of my patients, but it's not guideline based.
okay.
Dr. Rood, did you have any other questions about this case or anything you wanted to bring up with the group?
No, I don't think so.
Awesome. Anyone else from the group with any comments, questions? Alrighty, well, I want to give a big shout out to our 3 case presenters today, Alice, Dr. Fournier, Dr. Rood. We really appreciate you all taking the time and presenting the cases today. And I want to thank all of you for joining the session today. I know some of them had to hop off for some other meetings and things like that, but I'm so appreciative of all of you guys. So thank you so much. My only announcement for today is that our next session is going to be in the new year, which is so crazy. January 13th, and Dr. Gilfus will be discussing initial evals. So keep an eye out for that reminder. I hope you all have a wonderful Christmas, really happy New Year, ring in the New Year positively, and we'll see you all next year. Thank you guys so much.
Thanks, Mika.
Take care.
Thanks,
Bye.
everyone.